All right, so I'm going to say good evening. Welcome to this event of No Buts About It. Hopefully you get a chance to learn something new, know your risk about colorectal cancer. We have a dynamic group of panelists here today, and I'm going to introduce each one of them. I'm your host, Dr. Preston. I'm an assistant professor at Virginia Commonwealth University and also serve as the assistant director with the Massey Cancer Center Office of Health Equity and Disparities Research. I'm going to share some slides here and hopefully we can get this event going. Let's see. All right, so here we go. I'm going to start off by introducing our panelists. First, we have Dr. Debbie Cadet. The next panelist we have today is Dr. Khalid Mateen, Dr. Rebecca Branch Griffin, Dr. Torino Jennings, and Melinda Coughlin. These are the experts that we have here today. So I'm going to ask each one of them to introduce themselves and tell us a little bit about the organization you're with. And we'll start with Melinda Coughlin.
Thank you, Dr. Preston. I appreciate this. Hi, I'm Melinda Conklin. I'm the founder and executive director of Hitting Cancer Below the Belt, also known as HCB2, which is the acronym of Hitting Cancer Below the Belt. We're a Richmond-based nonprofit, and we're totally dedicated to colon health and cancer prevention. And we provide services and education here in the Richmond community and across the state that helps to prevent colorectal cancer. And we're extremely honored to be here tonight to help answer some questions. Thank you.
Dr. Jennings.
Hi, my name is Torino Jennings. I am the Chief Medical Officer of Capital Area Health Network. We're a network of 6 different offices in the Richmond and Chesterfield area. We are a federally qualified health center, so we service individuals that can afford to pay, that cannot afford to pay. We take everyone, and we do all we can to take care of primary care needs in our communities.
Thank you. Dr. Cadet.
Good evening, everyone. I am Dr. Cadet. I am a program manager for community health, education, and research at VCU Massey Cancer Center in the Office of Health Equities and Disparities Research. And my role is to bring cancer prevention, screening, and treatment information to you, the individuals in our community, so that you too can live a life free of colorectal cancer.
All right, Dr. Mateen.
Hi, everyone. Thank you for joining us for this important event today. I'm Khalid Mateen. I'm a medical oncologist at VCU Massey Cancer Center. Currently, I'm the interim chair of our Division of Hematology, Oncology, and Palliative Care. I've focused on GI cancers for about 20 years now, with a prime interest in research in colorectal cancer, and work with our surgeons, radiation oncologists, and our whole team here to provide multidisciplinary care for our patients with colorectal cancer.
And Dr. Branch Griffin.
Good afternoon, everyone. I am Rebecca Branch Griffin, and I am retired Director of Health and Counseling Services at Virginia State University. And I am a colorectal cancer survivor, one who had not a symptom of cancer, but ended up with stage 2A, I believe. Yeah, but, and you know, so it was a 2-year battle. It was a 2-year battle. Mm-hmm.
All right, and thank everyone for being here this evening. We also want to thank the Massey Cancer Center for hosting this event. We want to thank you, the participants. We want to get to know the audience here today, so you should be able to find a link pinned to the Facebook Live on the Massey Cancer Center site. So if you can, click that link, tell us a little bit about yourself, so that way we can get to know you as you get to know us. So we're going to go ahead and get started with some of our questions. We ask that if you have comments or questions that you would like to ask the panelists, that you do so. You can use the comment section there, post your questions. We ask that you like today's event. Also, share with your friends and family members. Do a watch Facebook, a watch if you feel the need to do so. And we're going to start with our first question. So what is colorectal cancer? So I'm going to start with maybe one of our providers here to kind of give us their take about what colorectal cancer is, and I'm going to make sure that I share the slides as well. So we have Dr. Mateen, if you don't mind, if you can kind of give us an overview about what colorectal cancer is, and maybe some ideas of how does it start? Because people may want to know, how does this start within our bodies?
Absolutely, Dr. Preston. So I think what's important to know is in terms of your body, where this is. So within your abdominal cavity is your large bowel, and that's really where colorectal cancer originates in either the colon or the rectum, which is your large bowel in your abdomen, in your belly area. And it's a cancer that can grow and spread like most cancers can. It can present with symptoms, or sometimes you can be asymptomatic. The reason why screening is so important for this cancer is because this is a cancer that can be diagnosed early with screening tests, even when you do not have any symptoms. And there are growths called polyps, which are benign initially, but then they become cancerous, and out of that grows a cancer. So that's why understanding that there is a precancerous stage that can be visualized and potentially removed before it becomes a cancer is very important.
All right. So I'm going to say that there's some questions that, I would have if I was an audience member, stepping back, from the answer you just gave, what are some of the differences between colorectal cancer, colon cancer, and rectal cancer? Are they all the same? If I'm an audience member, I would like to know, what are some of those differences? And, should I think of colorectal cancer the same as colon cancer or not?
In some ways, yes, in terms of for screening and in terms of how they behave and respond to different treatments, there are similarities, but the presentations can often be different. Rectal cancer, because it is lower down, can often present more likely with symptoms such as bleeding or blockage or change in bowel habits. A cancer of the colon that's higher up is a little bit more likely to be without symptoms. So there's some subtle differences, but when it comes to responses to different treatment options, fairly similar. Although the one caveat is that for rectal cancer, there is a strong role for radiation treatment, whereas there isn't really much of that for the rest of the higher up colon cancers.
Okay. So anybody else have anything they'd like to add to that?
I do have one comment for Dr. Mateen, and this is really a question. my understanding is that rectal cancer has a higher rate of recurrence, such as like 20% as opposed to colorectal cancer. So my understanding that rectal cancer can reoccur, unfortunately. Is that correct?
That is correct. And part of the reason is because of where it's located. It's in the lower down in the pelvis, and therefore, unfortunately, has a higher rate of recurrence locally within that pelvic area, despite radiation and chemotherapy, unfortunately, sometimes. So that's why we do tend to treat it more aggressively with surgery, chemotherapy, and radiation to reduce the risk. But unfortunately, it is a cancer that is a higher likelihood of coming back.
Okay. But it sounds like the actual rate of mortality and all that is very similar to colorectal cancer. And so I'm assuming that those folks with rectal cancer are definitely monitored beyond survivorship, I'm assuming.
That is correct.
Thank you.
Okay, thank you. So I'm going to move on to our next slide here. And you'll see me kind of go back and forth because it seems like this is the best way of sharing it. All right, so as I mentioned, if you're just not joining us, welcome. We have a group of panelists here today from different organizations that present, they represent community clinics, also Massey Cancer Center, our Hitting Cancer Below the Belt, and our community health clinic within the Richmond area. And so we asking that, if you just not joining us, feel free to comment, hit the like button. Hopefully you have some questions that you want to ask our panelists here today. We also want to get to know you as a audience, so feel free to hit the link that should be pinned to this Facebook Live on the Massey Cancer site, and we're asking you to complete that at your leisure so we can get to know you. So moving on to our next set of questions here related to knowing your risk, which is kind of, one of the reasons why we're here today, so people will understand their risk for colorectal cancer. What is something you would consider is a risk factor for colorectal cancer? And I'm going to ask Dr. Jennings if you will kind of start us off there, and then I'll move around to some of the other panelists so they can answer as well.
Sure. I think one of the things, thank you for the question. One of the things that we should always keep in mind as far as our risk stratification regarding colorectal cancer is a family history. So if you do have a family history of colorectal cancer, then your risk stratification is going to be in a higher category. And if you've had a screening test and you had polyps, any type of polyp, and I think there's a question from the audience regarding how polyps are developed, which is sort of an overgrowth of your normal cell population that is in the colon, and a polyp forms that as a result of that. And as Dr. Mateen mentioned earlier, it's very important that we find precancerous polyps so that they can be removed, because if they were to stay in your gut, then they could end up forming into a cancerous lesion. So again, family history is very important. The presence of polyps is very important. Also, the history of inflammatory bowel diseases. So anyone that has had Crohn's or ulcerative colitis, they're going to be in a higher risk category than individuals that are walking around. And risk is so important when we're deciding by what age you should be screened. Thank you, Ms. Melinda Conklin, for giving me that pearl there, because risk stratification is very important as we decide by what age all of us should be screened. So I think those are the most common areas where we stratify risk. The other things that come up are hereditary family diseases that are not as common, but if those types of things run in your family, you will probably already know about those.
All right. So thinking about other risk factors that may contribute to colorectal cancer. Does anyone else have anything that they would like to add, to that conversation?
Yeah, if you don't mind, I'm going to just mention something really quick. And Dr. Jennings, you're right on. You mentioned things you cannot control. You cannot control Lynch syndrome. You can't control family history. And usually at the young age when IBD actually is diagnosed, you can't really control that. But there are some things that you can control, and there's a whole prevention, colorectal cancer prevention side of hitting cancer below the belt. We talk a lot about nutrition and diet, which I believe, Dr. Preston, you had on your screen. We talk a lot about the importance of exercise. Oh my gosh, to stimulate the lymphatic system, to get rid of the toxins. We like to say, we are what we eat. Actually, we are what we don't eliminate. If we are unable to remove waste, we become that. And so that's one thing that we talk a lot about in regards to what exercise and also nutrition can do to help eliminate toxins from the body. And then at the same time, we talk a lot about breath work to help bring down stress, chronic stress and that sort of thing, and just something easy to do throughout the day. So those are 3 pillars that we focus a lot on. These are things that we can control, but Dr. Jennings brought up critically important items, that things that we cannot control that also put you at a higher risk.
We definitely don't want to forget
All
not making sure we don't smoke.
Correct. Yep.
Yeah, so that's what I was going to ask. Other risk factors such as smoking, excessive alcohol. Are those things that could actually increase our risk for colorectal cancer? And one of the things I want to know, I think, along the lines of things that we can change, can you talk to the audience a little bit about, additional risk factors that we can change, and maybe some risk factors, as mentioned earlier, that we cannot change?
Obviously, Dr. Jennings just mentioned, the things that we can control, and Dr. Preston, you just talked about, obviously alcohol and tobacco, all of those things. If we can take away from our daily behavior, is going to help our risk factors for all cancers. That's a given. But I will yield to everybody else on the panel, because there's a lot of other things that we can control, and I know they've got information about that.
All right. So what about diet? Dr. Cadet, do you have anything that you would like to let the audience know related to diet, that things that might actually increase our risk, those risk factors that we can change? Or okay.
Absolutely. My apologies. We always stress in our Screen to Save program, an NCI campaign for discovering and educating about colorectal cancer. We definitely encourage a diet high in fiber and reducing processed foods. So that's definitely a good place to start. You might say, so what's high in fiber? So you want fresh fruits and vegetables whenever possible. Reducing red meats, processed meats, definitely. And so, there comes some issues with that, right? Because we have individuals living in food deserts and who may not have access to fresh fruits and vegetables. But certainly we can reduce processed foods, rice, pastas, high carbohydrate foods, and certainly do our best to reduce sugars and that type of thing, and really stick to as a clean diet as possible to reduce your risks.
And I have to piggyback on what Dr. Cadet just said. She's right on with all of that. And with all of that fiber, you need hydration. That's going to be a brick in the gut if we're not hydrated, and most folks are walking around dehydrated. So hydration is critical in regards to getting enough water throughout the day to move that fiber actually through the digestive system. But at the same time, I think fat has gotten a really bad rap. And so there's good quality fats out there. We're talking avocado and fish and sprouted and raw nuts, all kinds of really good fats out there that help to heal and seal the gut lining. So I think, when it comes to actually, protection in our diet, you're absolutely right, Dr. Cadet, is being careful about those processed foods and those high sugar laden foods. But at the same time, go back to basics, as Dr. Cadet said, go back to clean food with water, lots of water.
So speaking of, that, makes me think about, areas that may not have access to some of those items, those food items that you just mentioned. So, it made me think about barriers to, colorectal cancer screening. Is there something, I guess, that we need to consider when we talk about, barriers to access to maybe healthier food choices that people should know about?
Yeah. Dr. Jennings, I know you can speak about this because you're leading FQHCs and you're in those areas, you see those areas, and you understand that folks don't have access to clean foods, right?
Yes, one thing I will add right away is that we're a Capital Area Health Network, and once a month, we actually give away clean foods. So we participate with food pantries and we give away food. So if anyone has, if anyone has a need, they can call 780-0840, let us know that you have a need, and we will make sure that some food is available for you. We also have some partnerships with some local farmers where we get fresh vegetables. So we do all we can to make those things available for individuals who cannot themselves afford it or don't have access to it.
Yeah.
Oh man, that's a great resource. Thank you for that. And so we have a couple of questions here that I want to make sure that we get those questions answered. Someone mentioned that they're turning 50 next month. Should they be screened for colorectal cancer?
I would say yes.
So it's a unanimous yes.
Yes.
And yeah, okay. So hopefully that individual get their screening scheduled, and next time that we have a Facebook Live event, they can tell us that they got screened and they had, good news to share with others. And maybe they'll influence other people to get screened as well. So there's a couple other questions that I see some of the audience members have asked. And so what I'm going to do, I'm trying to make sure that we ask the questions that are in line with where we are within this session. So let's see. There was a question about so I think we did ask it about the polyps, how polyps are developed, the discussion of how and why polyps develop within the body. So hopefully that person heard that information. And I'm going to say again that, welcome our audience members to this Facebook Live. No buts about it. We hope that you hit the like button, make comments, ask questions, listen and learn. And at the end of this, we hope that you get screened for colorectal cancer. So we want to thank our panelists again. They have been wonderful in providing us important information about colorectal cancer and understanding our risk for colorectal cancer. So we're going to keep moving, and I'm going to move on to our next slide here. So I'm going to share my screen. And our next item is kind of knowing the symptoms. So people are asking about their symptoms. How would they know what to look for when you talk about colorectal cancer? So we have several people that I believe could, give us a start on this. I don't know if who wants to start first, but I'm going to leave it open this time.
Yeah, so I think the key thing here is for people to realize is that watching out for symptoms and letting your provider know those and making sure that they address them is important, because even if the guidelines state that you should get colon cancer screening by a certain age, doesn't mean, unfortunately, that you cannot get colon cancer before that age. And sadly, one of the things that we are seeing is, unfortunately, a rising incidence of colorectal cancer in younger patients every year. So while we're seeing actually decreasing in the older age group, in the younger population, it's going up. So that's why the symptoms that were on the slide there by Dr. Preston are important to watch out for, and making sure you relay those urgently to your provider, and if they persist, push to get tested. And I think that's an important take home from today.
I'd like to piggyback on that real quick, because I think what Dr. Martini pointed out was that the incidence is going up in the younger age group. But I also want to point out that the level of the cancer or the grade of the cancer is higher in the younger age group. And oftentimes that's because they're ignoring symptoms and letting things fester for a longer period of time. So if you are having those symptoms of abdominal pain, persistent diarrhea, persistent constipation, change in your stool, nausea, things that make your gut feel different, bleeding, of course, do not ignore that. Do not think, well, I'm young, it's going to go away. If something is persistent, you do need to bring that to the attention of your provider. And if they do not respond right away, then force the issue and make sure that they really are present and listen to you.
I'm going to piggyback on that, because we're a nonprofit, we're out in the community all the time. And there is no age anymore to get screened. Like we talked about, should be screened by a certain age. If you are having symptoms of any age, do not disregard those symptoms. And you're absolutely right, Dr. Jennings. The research is now showing that those folks under 39, 71% of those folks are being diagnosed at stage 3 and stage 4, because the time of actual symptoms to the time of diagnosis is close to 300 days. So that's a long time to be disregarded, whether you're disregarding the symptoms or you have asked your provider, your medical provider, about these symptoms and they disregarded it. It's an issue that has really come upon us in the medical community, as all of us have to kind of, open our eyes a little bit, that colorectal cancer is not an old man's disease. Women have colons too, and young people are being diagnosed at a much higher rate. So you're absolutely right. Do not ignore any symptoms, and we can go over those exact symptoms not to ignore. So yeah, thank you for that.
And might I also say that I fall into that category of asymptomatic. I did not have any symptoms, no change in bowel habits, no pain, everything was well, no family history, no kind of abdominal issues or anything. So mine it was just there. And well, when it was diagnosed, it was stage 2. So I had been tested and everything was well. But I mean, when I went back for my annual exam a year later, there was colonoscopy, stage 2. So it was like, wow. So it's, and I must admit, I was not the healthiest eater. In the last 10 years, I've done so much better. But I was not, growing up, I was not the healthiest eater. And even though nurse practitioner, so what? I wasn't eating well like I should. So, but keeping my weight down, all of that. So it floored me. And of course, my treatment was aggressive.
Dr. Branch Griffin, thank you for that. The whole reason why our organization actually started was because of my husband, my late husband. We were married for 20 years, passed away due to colorectal cancer at age 43. He was diagnosed at 41 at stage 4, but he did not have symptoms, Dr. Branch Griffin. He didn't have any symptoms that I knew of that he relayed to me. And it was just a stitch in his side, which actually was his 9 tumors in his liver that, caused somebody to say, a doctor, you need to get a colonoscopy. And that's what revealed stage 4 colorectal cancer. So again, this is why this is so important. The silence that is wrapped around this disease in regards to the patient being silent about symptoms or not having any symptoms, you are asymptomatic. And then sometimes the providers also disregarding it because they're too young. This is why we're here tonight, is to break this silence. So I'm so glad you are here to help raise the level of conversation about this disease.
And part of it is individuals may not have health insurance, right? So let's be real. Virginia recently expanded Medicaid, but individuals may very well not have the resources by which to reach out to a provider to even get screened. So, what we're doing with our program is we're offering fit testing. So if you feel that you need to get screened and you don't have money for a colonoscopy, which is the gold standard, certainly a fit test, reach out to us in the pinned information. Please reach out to us. We can get you a fit test and help navigate you depending on the results of that fit test. It's very important. Everyone who's of age should be screened. Resources should not be a barrier. Okay. And that's why we're here. Resources should not be a barrier for you to get screened. If you're at that age, if you're in that risk category, we can help you with that.
You know what, and Dr. Preston, I think that to piggyback on what Dr. Cadet just said is probably the next conversation is like, what are the screens out there? Because you're absolutely right. There are fit screening tools out there. There's Cologuard, there's colonoscopy, there's all kinds of screens. So I know that Dr. Mateen and Dr. Jennings could talk a whole lot more about exactly what to ask your doctor for, so that might be the next, conversation.
Yeah, so that was one of the questions that the audience had. They wanted to get an understanding of what are the different types of screening tests that are available. What is kind of, one of the, I guess, the options that is most recommended by providers within your clinic, and for people who are asymptomatic and age appropriate versus someone who is symptomatic.
Okay, so I'll kind of give you 2 broad categories with that. There are stool-based tests, and then there's sort of what I would call more visual tests. So the stool-based test would be your, I think it was mentioned earlier, fecal immunochemical test, which is a fit test. So we all call it fit test. It's basically just taking the stool and placing an immunochemical on it to see whether or not blood is present there. We also have a fecal occult blood test, which is again getting a stool sample and testing to see whether or not there's blood in that stool. You guys may have seen the little cool commercial, looks like a little toilet seat talking about Cologuard. That's DNA in the stool. So those are what I would call the stool-based test. The thing about the stool-based test, they're more of a screening test for individuals that are not symptomatic. The FIT test and the fecal occult blood tests are annual tests, so they're done every year. The DNA test with the little cool toilet seat, where we give you sort of a package to take home and you mail back in, that is every 3 years. If you are asymptomatic, those are okay tests to have done. I always caution people though, if one of those tests is positive, then you're going to end up having to get the gold standard, which is a colonoscopy. So, as a provider, my preference is for patients to get a colonoscopy so that I can have as much information as possible if and when I have to refer to someone like Dr. Mateen so that they can have as much information as possible to manage the patient. So I just, and the colonoscopies in general are done every 10 years unless they have abnormalities, then we reduce the time in between your repeat colonoscopies. So that's kind of the categories I would put that into, your stool-based test and your visual test, which actually go through the colon with either, either full colonoscopy or flexible sigmoidoscopy, just to try to make it as simple as possible.
That's awesome.
Yeah, and I would just add to what Dr. Jennings said is the other part, the reason why also colonoscopy is felt to be the gold standard is because you directly visualize the entire colon and the rectum. And if there are polyps, they can be removed by that procedure. But certainly we realize it's not a test that maybe everyone wants to get. And therefore, it's still better to get one of the stool-based tests than not get any test at all.
So I want to say, one of the things I've found, dealing with people within my own family, there's a tendency, people there's some stigmas, related to getting a colonoscopy because of, the area of the body that, is being probed. And so, are y'all, how do you talk to somebody about getting over some of those stigmas or fears, some of those barriers to receiving colorectal cancer screening?
Yeah, I think for my patients, because I generally see them if they've already had a prior diagnosis and then they're doing subsequent testing to make sure they don't have a recurrence or a second cancer. It's a little bit easier because those patients generally are more highly motivated to get their screening test. And I think once they realize that it's a test where you can be sedated for and what it can prevent down the road, patients are willing to go through that. And I guess for my subset, they've already had a diagnosis. As I mentioned, they're more motivated. And I tell all my patients, having already had one of those procedures myself, it's the prep that's the worst part. The procedure itself is you don't remember anything about it, and by the time you wake up, it's all done.
Yeah, and I can piggyback on that just because we're out in the community quite a bit, and there is 30%, right, of those folks that are just not going to get that test. And so we do a lot of work in regards to educating folks about their screening options, such as the FIT, which is a fecal immunochemical test that Dr. Jennings talked about, and Cologuard, the cute little box that you see on commercial. The non-invasive, simple in-home screening tests are available to them. Going back, if you do have insurance, but luckily, if you're listening here in the Richmond area, we have 22 free clinics that most of them have some sort of a colorectal cancer screening program. So we're very philanthropic, and we do take care of those folks who are underserved in the Richmond area. So we can get people plugged in. But at the same time, those folks that do go ahead with that non-invasive, simple test at home, if it comes back positive, over 70%, close to 75% of those folks go ahead and opt for a colonoscopy. They would have never done that if they hadn't gotten that test to begin with. Mm-hmm. So it's these in-home non-invasive tests really do serve a purpose, whether you have to do it every year with FIT or 3 years with Cologuard. However, they can feed people in that just weren't going to get that test done. And I think that's the beautiful partnership with both colonoscopy. By the way, we love colonoscopy because of that picture, because of that video. It's a very clean view of the whole colon and the rectum, which is extremely important. But at the same time, if those folks that we're meeting with in community, and there's a lot of them that are not going to get that test, we feel really comfortable about offering these other simple tools as well.
All right.
I'm sorry. And we do have to remember that this is a screening test that can benefit you. So although it may be invasive, and some people think it's more invasive than others, but we can never forget that this is a test. If it is positive and we identify it, your life can be saved. And that is nothing to play with. If your life can be saved just by us having to get a sample or a test done for you, then that's definitely worth doing.
And thank you for reminding me of that, because we do tell folks that ultimately, if it comes back positive, you're still going to need to get the test. You're still going to need to get the test, which is actually going to take care of any issue at that point in time. And just so everybody that's listening here tonight, it's really important that when you have a colonoscopy and you have a prep and you have the procedure, to please tell people how easy it is. Please make our life a whole lot easier, the panel's life a whole lot easier. And please spread the word that the prep, low volume preps are not that bad. It's a nap, and the colonoscopy is easy peasy, because that actually can save lives. So everybody out there has a voice in regards to helping to save lives out there. Just want to put in that plug.
And also, when I well, before COVID-19, when we got together for family dinners and family reunion. I guess because I'm a living witness, they kind of listened to me. So it was easy. And I always took information on colon cancer, colorectal cancer, the testings, all of that, and just gave it out as part of the family reunion information that we give out. And so I was a pretty credible person, and they believed me because, you know, I went through it. And the key was being diagnosed early, even though stage 2 and the treatment was aggressive. But I kind of have some clout with family members.
All right. So thank you all for that. I'm going to pause for a minute here and make sure that if you're just now joining us, that you hit the like button. We have, should be a link tied to this live event where you can tell us a little bit about yourself. So please complete that. That survey item is short and sweet. It's just to help us to get to know you as an audience, and so we can better serve you. One of the things also, I want to make sure that we thank our panelists again, who have been providing some valuable information today, and we hope that this is one of many that we can do for the community. One of the questions I think that kind of came up, I see here, is, if we get a positive, does that mean that I have colorectal cancer? Should I be worried? Does that mean I have colorectal cancer if I get a positive?
So I guess it's the question of potentially a positive stool test, right?
Yeah,
okay.
Yeah, positive stool test.
No, it's not a given, and that's why you want to get a colonoscopy to find out what the cause is. But a FIT test basically is telling you if there is a presence of blood there in your sample. That can be from multiple different things. But of course, if you do have a positive test, you want to make sure you do get that test to be sure what's going on. Polyps can show positive results as well. Other, reasons for bleeding, like abnormal blood vessel formations. But of course, unfortunately, it can be a tumor as well. But that's why the next step is to do a colonoscopy or other procedure like that.
All right, thank you. All right, so what I'm going to do is I'm going to go back to our slides here. I'm going to share. And again, hit the link there, fill out the information so we can get to know you as an audience member. So, we've been talking about the different available screening tests, and talking about ways to prevent colorectal cancer. So next we have a short video that we would like to play for you. And at the end of this video, we'll start back with our panelists. We got our video. All right, so here we go.
An important message from your gastroenterologists across America.
Colorectal cancer is the second most common cancer killer in America.
The death of Chadwick Boseman at the age of 43 to colorectal cancer fills us all with so much sorrow.
It reminds us that colorectal cancer happens in young people.
And that Black men and women have the high rates of getting the disease and dying from it.
But we can stop colorectal cancer in its tracks.
The disease is preventable, treatable, and beatable to get screened at the right age.
For most, screening starts at age 50.
But for high-risk groups like Black men and women, screening starts at age 45.
If you have a family history of colorectal cancer or other medical risk factors for the disease, screening should start at age 40 or even earlier.
Chadwick Boseman's untimely death is a wake-up call for all of us.
We, as Black gastroenterologists and colorectal cancer warriors, are fighting to make colorectal cancer screening and prevention a priority.
When caught at an early stage, the survival from colorectal cancer is 90%. But when caught at late stage, the survival is only 11%.
And this is why prevention and paying attention to any symptoms you may have is so important.
Talk to your doctor today about colorectal cancer screening. It can save your life.
Visit cancer.org and gi.org for more information.
All right, thank you. So that's a very good video, I think, that that they put out, and we can just have a little bit of discussion about we can just have a little bit of discussion about ways to prevent colorectal cancer. There's some information. That's a very good video, I think, that that they put out, and we can just have a little bit of discussion about I think we're getting some feedback from someone. All right, so hey, we're in the new age of technology, so everybody has to be a little patient, and we all know that these are challenges and that we're having to work through, so that's okay. But we're here to help people, so that's our objective for today. And like I said, that video there is very interesting, and we want to kind of maybe talk about some of the things I saw in there. It talked about, African-American men, what age that they should start their colorectal cancer screening. And it also talked about women, African-American women. Do y'all have any, comments or things that we should add to that you saw from that video?
I'll just start the conversation with a broad stroke in regards to, a lot of people like to use the word awareness, but at our organization, we like to use the word mindful. It's just about being mindful about how we're moving through the day. How are we eating? What are we eating? Pay attention to what we're eating. How are we moving throughout the day? Are we getting up? Or are we staying in our desk for 2 or 3 hours? How are we breathing? How are we lowering our stress levels? At the same time, what is our body telling us? Are we eliminating every single day? And if we are, do you feel like you're fully eliminating? It's again, that broad stroke of just being really mindful about what our body is telling us, and at the same time, how we are doing basic things throughout the day. However, I do realize in the African American community that there are very large barriers, such as food deserts, access to care, transportation issues, and that sort of thing. So, we can talk more about that because those are real issues in regards to health disparities in our country that cause, cancer to prevail.
Mindy, I appreciate you talking about food deserts again. Dr. Jennings, someone asked that you share that number, and I'd be happy if you can share the number that you gave out about the pantry.
Okay, if you call 780-0840 and let someone know that you have an issue as far as living in a food desert or you have a food need, then we can have you signed up to benefit from our food pantry. There's also a farm called Shalom Farms that we partner with that has natural vegetables that we make available for our patients and our community. So please take advantage of those opportunities to get fresh, natural fruits and vegetables.
It's wonderful.
All right, thank you. Thank you for that. I think that's a very good information for everyone to hear. especially living in communities where access to food is one of the barriers to reducing their risk for colorectal cancer. So some of the things I think we also need to talk about are, I think there are some questions related to treatment options. There's a couple of, there appears to be a couple of questions asking about, you know, what is the standard treatment for colorectal cancer?
Sure, Dr. Preston, I'm happy to start addressing that at least. So when it comes to a cancer of the rectum, which is the lower part of your large bowel, that's generally a cancer that is often treated with what we call a multi-modality approach, wherein you generally will require chemotherapy, radiation, and surgery. And that's what we at Massey Cancer Center approach it from a multi-pronged effort where we sit and discuss every patient with rectal cancer and make sure the appropriate sequence of therapies is done. If it's a higher up colon cancer, so it's in the abdominal cavity, then generally if it's localized to the colon, the first treatment is surgery, surgical removal, and then depending on what stage it is, chemotherapy may be warranted. Unfortunately, if it's a more advanced stage 4 cancer, then generally the mainstay of treatment is chemotherapy. There may be role for surgery and other treatments as indicated. The other thing that's always important to realize also is no matter what stage of cancer you have, you should always ask about clinical trials, because clinical trials is how we advance treatment. We have new drugs that basically improve the standard of care in cancer treatment, and we have multiple different clinical trials open at Massey for different diagnoses and different stage of colon cancer as well.
I shared earlier that my treatment was aggressive, and it was. I started out with the first 6 weeks with daily oral chemo and radiation. And after that, it shrunk the tumor somewhat. But after that came the surgery and removal. And I guess I was shocked when I was told I had to have an ileostomy for 6 months. But, you know, at least it was temporary. And following the surgery, removal and the ileostomy, I ended up doing more chemo infusions for, I think I did maybe 6 treatments. And then maybe a month and a half after the treatment, the reversal came. So didn't want to go through all of that, but it was necessary.
But Dr. Branch Griffin, we have a lot of volunteers with our organization that have had similar stories. That reversal is successful. So it's okay.
Yes.
To have, right? So can you speak to that a little bit? Because I know that was scary at first. Yeah.
Well, you know, early in my nursing career, I took care of so many patients that had whether colostomies, ileostomies, and I used to think to myself, God, I hope I never have to deal with this, because it was just, you know, but here I am in that same situation. It was scary, but I guess I had a different outlook because I knew that it was temporary. And I call it my victory surgery. I mean, I was just so happy to go and have the reversal done, because I knew that was the end of it. But you know, I guess the part that was more frightening was what the chemo had done to my body, and whether or not I'd be able to continue with it. And I was. And I mean, to miss a treatment because my blood counts were too low, you know, that really bothered me, because I wanted to get it over with so I can rush on to, you know, the victory surgery. But yes, it's scary, but you can make it through, even if it's a permanent situation. Because I've had some individuals who had the same stage that I had, and they, you know, theirs was permanent. So, you know, we talk a lot, and you do what you have to do to survive.
Right. Well, and we have an advisory council at Hitting Cancer Below the Belt, and one of our members has an ileostomy, and she is a marathon runner, and she's young, and she's a huge advocate. And there is a support group, just letting you know, Dr. Preston, there is a support group here in the state of Virginia for those folks that aren't able to get the reversal.
All right, and thank you both for that, and thank you, Dr. Branch Griffin, for your insight into what you've had to do and give people hope for if they've actually been diagnosed with colorectal cancer. All right. All right. So we're down to only a couple of minutes left. So what I'm going to do is I'm trying to see if we have any additional questions that I need to cover. If not, I'm going to share my screen again to make sure that people are aware of what our call to action, you know, what do we want to accomplish with, you know, these types of events. And that is, our call to action is to try to get 80% of the people in the community screened that are age appropriate. So if you're age eligible for colorectal cancer screening, we want to try to get 80% in our community screening for colorectal cancer. So I guess the question is, you know, do I need to be screened for colorectal cancer? And the answer to that is, if you're 45 or older, we say yes. If you have some risk factors such as family history that increases your risk for colorectal cancer, then, you know, if you're younger, that you need to ask your doctor to see if you need to be screened for colorectal cancer. We know that, as mentioned earlier, there's been an increase in the number of people who are being diagnosed at earlier age for colorectal cancer. So sometimes by the time they find out they have colorectal cancer, it's later stage, and it's more difficult to combat the disease at that time. And so we all know Chadwick Boseman kind of raised the awareness about colorectal cancer when he passed earlier this year. And so we're trying to make sure that people know their risk for colorectal cancer. And if you have any questions, as Dr. Jennings and others have said, you know, ask your doctor. If they say, well, you know, it may not be that, you know, you may have to push the envelope a little bit and let them know that, you know, you have family history or other things that may increase your risk for colorectal cancer. And anybody else want to have anything to add before we close out?
Yes, I would like to invite our audience to participate in our program. We have a Screen to Save program where, if you're interested in being screened for colorectal cancer, we can get to you a fit test. Just simply put your information in the link and we will follow up with you. We can connect you with HCB2. And if you are so inclined to bring one of these presentations to your church community or a group that you're interested in, we certainly have a program, the Colorectal Health Research Champions. You heard Dr. Rebecca Branch Griffin talk about how she is now the voice, bringing this to her family and so forth. And we have a program. It's actually a research effort funded by the NCI, the National Cancer Institute, where we are training advocates to go out into their communities, their respective social circles, to talk about getting screened for colorectal cancer. And again, just by calling us at 804-827-0000, we can plug you in and get started learning how to bring this very important information to your communities in layman's terms. All right.
Anybody else?
So Dr. Preston, I think I saw a question about minority accrual on clinical trials, especially with regards to Black patients. So I just wanted to address that because the Massey Cancer Center is one of 13 minority underserved ENCORE sites around the country, where we really pride ourselves on minority inclusion in clinical trials. And we actually, consistently have been at about the 25% mark or so for NCI clinical trials. So we absolutely value minority accrual in clinical trials because we feel that that represents the population of our community, and that's a core value of the Cancer Center.
And I speak
all right
really quickly.
Go ahead.
Since we're showing Chadwick Boseman and he happens to be an African-American male, I do want to point out kudos to efforts such as everyone that has been on the screen today, because we know that in the past 10 years, even though the cancer, there's a huge disparity with the deaths related to colon cancer and all cancer types, especially among African-American males. But in the past 10 years, that gap has decreased. Now, we can't be satisfied with that decrease in the gap. If you want to look at where it was maybe 10 years ago, it was about 50% higher rate of cancer deaths in African-American males. Now it's about 20%. So that 30% decrease is substantial. Those are lives that are saved. And I want to implore all other African-American males to make sure you're doing your part to encourage your peers to do all they can to be screened so that we can continue to decrease that disparity among our community.
Dr. Jennings, I'm going to piggyback on that because I can make it really easy to bring up the conversation among peers. Hitting Cancer Below the Belt has a very large inflatable colon, and we travel all over the state of Virginia, whether it's health fairs, community organizations, civic groups, corporations, and we love to have our large inflatable colon there as we do presentations in regards to education about prevention and early detection. So again, yes, absolutely. We can do all kinds of things to help raise the level of conversation about colorectal cancer. And it's extremely important. So yes.
All right. So thank you all. Thank the audience for listening to us today. And we hope that everyone enjoyed and actually got some information that will help them, in the future. So again, thank you. And we look forward to seeing you all. And what's the message we want to get everybody? Hey, know your risk and get screened. All right. Bye-bye.
Bye.
Bye-bye.
Right. Good night, everybody.
Good night.
Good night.
Bye.